So for today's call, we will provide an overview of the Achieving Cardiovascular Equity project that we call ACE. Then Dr. Joseph, our clinical lead, will discuss some of the clinical aspects of hypertension, as well as how social determinants of health can impact patient outcomes. Then Allison and Dr. Adesanya will discuss some of our lessons learned and resources. And finally, our senior researcher, Evelyn Corshi, will review our data. A few housekeeping reminders. We have everyone muted for this call, so please submit any questions via the chat function. Also, as a reminder, this presentation is being recorded. So we have a few acknowledgements to get us started. The Achieving Cardiovascular Equity project is funded by the Ohio Department of Health and administered by the Ohio Colleges of Medicine Government Resource Center. The views expressed in this presentation are solely those of the authors and do not represent the views of ODH. Also, this course is eligible for 1 hour of CME through the Ohio State University Center for Continuing Medical Education, as described on the slide. All of the speakers and the planning committee members have no relevant financial relationships to disclose. And upon completion of this educational activity, you'll receive an electronic evaluation from the Center for Continuing Medical Education. Please go ahead and complete that evaluation because your feedback is imperative to the quality of this educational activity. The educational objectives are listed below for this course. And we would like to thank our project sponsor, the Ohio Department of Health. And I've also included the ACE team members who are joining us today to share our findings from the ACE Quality Improvement Project. We have Allison Lorenz, the Assistant Director of Quality Improvement Science with the Ohio Colleges of Medicine Government Resource Center. Allison is also the PI on this project, and she will be providing a project overview today.
Thanks, Wendy. All right, let's go to the next slide. So I just want to start out with a little bit of the reason why we're doing this work. So it is well established that hypertension control rates among non-Hispanic white adults are significantly higher than non-Hispanic Black adults. So we see that there is a shown disparity there. And hypertension contributes to about 33% of all cardiovascular disease and 43% of heart disease in Black populations. And in addition, Ohio adults have a higher prevalence of stroke and heart disease compared to other adults in the United States. On the next slide, in Ohio specifically, heart disease claimed just over 30,000 lives in 2020, which was the 11th highest death rate from heart disease in the United States. And heart disease diagnoses in Ohio result in about 10.3 potential years of life lost in the white population compared to 18.4 years within the Black population. So all of this data shows us what a pressing issue it is that we need to be focused on in Ohio. On the next slide, over the years, we have seen a lot of guidelines that have come out detailing the optimal levels for blood pressure control. And these guidelines vary from each other, but the consistent remains that regardless of what guideline it is that is being addressed, there are disparities with more non-Hispanic Black patients consistently having higher rates within uncontrolled blood pressure than white patients. And so we see this as a consistent, prevalent, ongoing issue that is impacting a lot of Ohioans. And so that's what has led us to focus on this topic today. And so because of these disparities, we created the Achieving Cardiovascular Equity Quality Improvement Project. So on the next slide, we can see this project focuses on reducing deaths due to myocardial infarction and stroke from cardiovascular disease, with a specific focus on reducing disparities between Black patients and non-Hispanic white patients. And so our team has set 2 primary SMART aims, and SMART stands for specific, measurable, achievable, realistic, and timely. And these aims are to improve the percentage of Black patients with controlled hypertension from 71.5% to 78.6%, and to improve the percent of all patients with controlled hypertension from 74.8% to 82.3%. On the next slide, to achieve these SMART aims to improve, actually, I'm going to have you go back, Wendy, to the previous slide you were on. One before that. Thanks. So to achieve these SMART aims to improve blood pressure control and advance health equity, we sought to identify patients with undiagnosed hypertension, which were those patients who were established within the primary care sites who had high BP readings at a prior visit, but no established hypertension diagnosis. Improve the management of adults with hypertension through following appropriate treatment and referral algorithms, and then screen for and address social determinants of health among the target patient populations. So now I'm going to skip forward to that key driver diagram that Wendy had pulled up for us here. And on this slide, there's a lot of text, so I'm not going to go in depth to discuss it all, but I do want to share that the way that we've structured this is on the left-hand column, we've identified our global and SMART aims, which I've already shared. In the center is our key drivers, or those buckets of what we think will really drive teams forward towards achieving improvement. And then on the right side, we have our interventions, or the tests of change that we think are going to impact improvement. So this is really our theory of change that we have used to guide project activities from the start through post-implementation of the effort. And we will share this with participants afterwards if you're interested in reviewing more in depth, but we'll be talking about quite a few of these interventions on the remainder of the call. On the next slide, I did want to share that as sites participated in this initial project, we asked them to not only implement that key driver diagram, but use a established clinical change package and patient resources, which included testing plan, do, study, act cycles, or rapid cycles test of change, and engage in data feedback biweekly to ensure that the data that they had to guide those PDSAs was actionable. And all of those things were part of testing the interventions. And so sites, when they signed on to do this project, they engaged in all of those activities. Additionally, they submitted patients to referrals if they thought they needed some services that were outside of the scope of what they were providing. So there was a lot that happened in the project, so we're going to take the next several minutes to go over the work that sites engaged in more detail. So I'm going to turn it over to Dr. Joseph to talk about some of the more details that led to this project in a little bit more depth.
Great, thank you so much, and welcome everybody today. Thank you so much for joining us. We really appreciate it. Next slide. So when we look at our project, achieving cardiovascular equity, we know there is a critical need for addressing blood pressure control. And as you see from this slide, we really think that as at the intersection of addressing social needs, QI process and process measures, and patient and provider engagement, things like checking blood pressures appropriately, using treatment algorithms. On the patient and provider engagement side, working on implicit biases, cultural concordance, and cultural humility. And on the addressing social needs side, things like screening for social needs, as well as referrals to address social needs. Next slide. So one of the first things that we embarked on with this project was, how do we find individuals with undiagnosed hypertension? Those individuals that are defined as hiding in plain sight from the Millions Hearts initiative. Next slide. When we look at the individuals who are unaware that they have hypertension, and here we're using a blood pressure greater than or equal to 140/90, we can see that this constituents with this are around 11.5 million people. When we look at aware and treated individuals, it's about 16.1 million people. And when we look at aware and untreated, it's about 7 million individuals. So those individuals who are hidden in plain sight are actually a very large group of Americans. And this uses the greater than or equal to 140/90 guidelines. I know some of your practices use greater than or equal to 130/80, and that even expands these numbers that we're looking at here. Next slide, Wendy. When we take a closer look at the individuals who are unaware, around 81% have health insurance, 83% report having a usual source of care, and 63% have received care 2 or more times in the past year. So these are individuals who, are actively engaging in their care and do have insurance. So this is a group that we definitely can engage with to recognize hypertension in these individuals and then appropriately treat where necessary. Next slide. When we look at controlling high blood pressure measures, and this is from the National Quality Forum, the measure definition is the percentage of patients 18 to 85 years of age who had a diagnosis of hypertension and whose blood pressure was adequately controlled, less than 140/90 during the measurement year. And then we give the ICD-10 code there on the right. Next slide. And so there are really 4 steps in this process for finding patients with undiagnosed hypertension. And I'll start with the green arrow. We want to implement a plan for addressing the identified population, compare to local, state, or national prevalence data, establish clinical criteria for potential undiagnosed hypertension, and then search for the EHR data for patients that meet the clinical criteria. Individuals start at various points in this process, but the important thing is to really make it through this 4-step process to identify individuals with undiagnosed hypertension. Next slide, Wendy. The sample stepped approach here really defines the amount of resources that are needed in order to identify individuals based on the criteria for blood pressure. And so you can see that as you use more stringent criteria, so for instance, the blue dot, one value greater than or equal to 180/120, there are fewer resources for hypertension confirmation. And these more conservative criteria have a higher positive predictive value. As you use more liberal criteria, like 2+ values greater than or equal to 140/90, there is a lower positive predictive value, and there are more resources needed for hypertension confirmation. Next slide. So some of the next steps, are that hypertension patients can be easily missed in clinic settings, and using the electronic health record can really help to identify these patients. When we think about putting this into practice, we can all use a tiered approach to bring patients back for evaluation that will fit into our own clinics and how we are doing this within our own paradigms and what will work best for us based on the resources that we have in order to identify individuals with undiagnosed hypertension. Next slide. Next, I would like to speak about the social determinants of health or non-medical health-related social needs. These are social needs that we know are critical in the long-term outcomes of individuals with hypertension. And these social determinants of health, or the non-medical health-related social needs that we're kind of talking about here at the individual level, are things like economic stability, neighborhood and physical environment, education, food, community and the social context, as well as the healthcare system. And within that, we know that these individual social needs really impact health outcomes for individuals, whether that be morbidity, mortality, life expectancy, healthcare expenditures, health status, etc. There's a lot of work to show that these factors are related to about 80% of the outcomes for individuals with hypertension. Next slide. When we look at the social determinants of health effects on hypertension, when we think first about healthcare access and quality, there have been a couple of major interventions. Think about the Affordable Care Act, where the impact here was increasing insurance coverage for millions of adults with hypertension that allowed access to clinics, as well as access for treatment, as well as access to medications to better manage hypertension. There are also a number of community health worker programs. One of them is a 12-month intervention in lifestyle changes, diet, and medication algorithms that showed significant decreases in both systolic and diastolic blood pressure. On the theme of economic stability, we know that there's a higher prevalence of hypertension among patients who may have a lower income. And then on the neighborhood and built environment, when we look at neighborhoods with healthy food options, they are loaded to have lower rates of hypertension prevalence in these communities. Next slide. So, when you're thinking about this and you're in clinic or you're a clinic manager and you're trying to figure out, when should we ask patients about social determinants of health or non-medical health related social needs? It's important to note that patients' needs change frequently, and that what we've seen from this project and other projects is this is not a one-time assessment. So, right now, for instance, the rates of food insecurity are increasing due to some of the rollbacks with the public health emergency ending and individual subsidies decreasing over time. And so if we screen individuals in February for food insecurity, and we screen individuals now, there may be differences in answers based on the current climate and context. So it is not a one-time assessment. We also try to figure out, well, how often should we assess individuals? And I think much of that is to be determined, particularly at the clinic level. Every clinic is different. Every population is different. And so trying to assess that and determine that is something that you can do within your clinic, as well as within the population of focus that you're working with. A great opportunity for like a community or a patient advisory board. Next slide. Ways to refer patients to services. The first way in many of our clinics is in-house social workers that help identify needs and available community resources. And so, many of our systems, including the EPIC system and the systems, other similar systems around the country, have built-in questions around social determinants of health and non-medical health related social needs. There are also models like the Pathways Community Hub model here in Ohio, where you can input an individual's information into a secure platform in the Pathways Hub. And that individual can be seen by a community health worker in the community where they live. And that community health worker actually goes directly to them, goes to their homes, and is able to ask questions on 20 different non-medical health related social needs. And not only ask the questions, but enter them into pathways to get those social needs addressed. Lastly, there are electronic referral systems such as Healthify, Bertha, Unite Us, and CliniSync, where within the system, you ask the questions in the electronic health record. When somebody identifies as a positive, there are resources within the electronic health record where the individuals can be referred to in order to eliminate that social need that the person may have or address that social need. Next slide. When we think about the Pathways Community Hub model, it's important to note that we have pathways really around the state in all of those areas that are in color on this map. And there's been expansion even with the last couple of years, and a lot of conversations about how do we expand some of the hub models to some of the to the counties without access currently. So that is an ongoing process, but a lot of coverage across our state. Next slide. And with that, I pass it back for the key learnings and resources.
Hello. So my name is Ayo Adesanya, and I'm an instructor in family and community medicine at OSU. Together with Miss Allison Lorenz, I'm going to share some of the key learning points and resources from the Achieving Cardiovascular Equity quality improvement project. And thank you so much, Dr. Joseph, for your introduction of the work there. Next slide, please. To outline our key learning points, we first advise use of a hypertension treatment algorithm, and we'll share and discuss our hypertension treatment algorithm in the upcoming slides. We next advise coordination of timely follow-up appointments for patients with uncontrolled blood pressure, and we'll share some example process maps. Ms. Lorenz will then discuss other key learning points from our work, like setting up a self-measured blood pressure program and making sure there's a system in place to ensure appropriate blood pressure training for new clinic staff and flow pools. Next slide, please. First, with the treatment algorithm. We share here 2 possible approaches to treating and controlling hypertension for your team to review. In the ACE-QI project, we encourage use of an updated treatment algorithm, adapted from the SPRINT blood pressure trial, utilizing chlorthalidone rather than hydrochlorothiazide as a preferred first-line thiazide therapy. This algorithm was adapted from the classic treatment algorithm presented here on screen right, that was used in the Kaiser healthcare system and the Better Health Partnership member practices. The classic algorithm showed strong improvements in blood pressure control in diverse patient populations, but may lead to underdosing of thiazide therapies. We will walk through both of these algorithms in the upcoming slides. The next slide, please. So in the updated treatment algorithm, step 1 includes lifestyle modifications and initiation of either chlorthalidone or amlodipine. If the blood pressure is not at goal, then an ACE inhibitor or an ARB is added to their therapy. If blood pressures are still not at goal, then the initial thiazide or calcium channel blocker is increased, followed by potential addition of the other first-line agent. Subsequently, mineralocorticoid receptor antagonists and other antihypertensive therapies are considered. This treatment algorithm really strives to utilize different mechanistic approaches to treating and controlling high blood pressure. Next slide, please. In the classic treatment algorithm, step 1 includes lifestyle modifications again, and an ACE inhibitor or ARB thiazide combination medication. Step 2 and subsequent steps involve up-titration of this medication, subsequent addition of a calcium channel blocker, and thereafter adding mineralocorticoid receptor antagonists and other antihypertensives as needed. Both of these shared algorithms are intended for non-pregnant adults in treatment of primary or essential hypertension. As always, treatment should be guided by thoughtful laboratory monitoring, consideration of comorbidities such as albuminuria, chronic kidney disease, coronary artery disease, and in heart failure, and should be patient-centered, which may impact antihypertensive medication choice and addition of multiple agents versus up-titration of a single agent. Many hypertension treatment algorithms exist, and here we have shared the approaches introduced in our ACE-QI project. Regardless of the selected algorithm, having a hypertension treatment algorithm in place is an utmost important component of improving hypertension control at both individual and population levels. Next slide, please. In our next key learning point, we strongly advise timely follow-up care for patients with uncontrolled blood pressure. Next slide, please. By timely, we really encourage 30-day follow-up visits for all patients with uncontrolled blood pressure. Here, we present an example clinic process map to ensure 30-day follow-ups for all patients with blood pressures above 140/90. Having such a process map in place most effectively ensures timely follow-ups, underscoring the importance of blood pressure control with both patients and clinic team members, avoiding treatment inertia, and achieving timely blood pressure control for all of our patients. And the next slide, for clinics with physician scheduling challenges, other team members such as clinical pharmacists may also be involved in coordination of timely follow-up care as well. I will now turn things over with Miss Lorenz to talk about other key learning points from the Achieving Cardiovascular Equity project. Thank you.
All right, thank you so much. So the third key learning we want to highlight today is considering setting up a self-measure blood pressure or SMBP program. So on the next slide, we used SMBP programs to encourage home blood pressure monitoring and promote measurement of blood pressure by individuals outside of the clinic setting using a validated automatic upper arm device. So this is different than systems encouraging patients to go to the pharmacy kiosk or use a manual device or a cuffless BP monitor, and is shown to be an evidence-based strategy when combined with clinical support. We strongly encourage with the clinical support to have staff trained and assigned to patients that are seen within the clinic to follow up with them at home and make sure that they are having any questions they have addressed around the process, and that they have support to make sure they are following through with the daily blood pressure, and they have any of their concerns proactively addressed. So best practice for this program then does ensure, and we'll go to the next slide here, that all patients with an elevated blood pressure or ongoing diagnosis of hypertension have a prescription for a home BP device or already have one in their possession. So through the course of the ACE project, we heard from several sites that sometimes it's challenging for patients to obtain that home blood pressure monitor, even with a prescription. In this case, they aren't readily accessible monitors available through the clinic. And so consider setting up a loaner program if there is a need. Some of these loaner programs were often run through an affiliated pharmacist and shown to be effective. We encourage that clinics ensure all patients being asked to take their blood pressure at home, again, have that assigned clinic staff member to provide that patient support and patient education, as well as establish a routine standardized process for sharing the home data with the clinic staff. And I'll highlight a tool available later in the slide deck here. For those sites that are considering setting up an SMBP program, we do have some CPT codes available that can be used for reimbursement. So on the next slide, we have these outlined. The CPT code 99743 can be used once when a staff provides SMBP training, device setup or calibration, and or instructions for patients how to use the monitor to monitor their blood pressure at home. And then CPT code 99744 can be used once a month for the ongoing treatment, such as electronic or in-person review of the blood pressure logs, and the provider averaging the patient's BP readings to inform next steps. So both of these codes are available and can be used if they're not currently being used within your office setting. And then lastly, our fourth sort of key learning we want to highlight today is to make sure that there is a system in place for proper BP measurement and treatment that ensures new staff and float pool staff are appropriately trained. So the clinical change package that we have been using through the ACE project provides evidence-based best practices, including identifying undiagnosed hypertension, providing effective treatment, utilizing some of the tools discussed today, establishing community connections and referral networks, and making sure that the social determinants of health are taken into account, and provide, as well as provide QI tools and training. So there's a lot of resources available in this change package, and the change package is publicly available on our website, but we can also send it out after this training to anybody who is interested. In addition to the topic areas, there's multiple tools that are provided to encourage effective and consistent treatment for hypertensive patients. So these are inclusive of everything on this list, but it sums up into these evidence-based medication algorithms. So these updated and the original one that we had, as well as process maps for the follow-up referrals that were reviewed, templates for visit referral content, medication reference list, unified drug list, and combination med lists, and resources for incorporating home blood pressure monitoring within the clinic, such as using a sample blood pressure log. There's a lot of different tools within the change package, so we'll highlight a few more here, but they are all, again, publicly available. So on the next slide, completing this clinical change package and created to complement some of the information in it is a set of patient education resources. These patient education resources are written at about a 4th grade reading level so that they are accessible. They reinforce messages within that clinical change package. They address 5 primary areas for patients with high blood pressure. Those are medication, again, the home blood pressure monitoring process, physical activity, and healthy food and eating less salt. So primarily following those DASH diet guidelines that are often used with this patient population. We also do include on those patient education resources some special notes for Black patients with high blood pressure readings. And we do take into account social determinants of health within this patient education materials. On the next slide, then, we have a couple more images of some of the tools that are available within the change package. So these are some of the training tools that are available for office staff. So these go in a little bit more into some of the interventions that are outlined within the key driver diagram, as well as best practice for how to take a blood pressure accurately and when to repeat it if your patient is presenting with a high reading. And then lastly, we have on the next slide, again, more patient resources that are available within that clinical change package, including the blood pressure log that can be used by patients who are engaging in taking their blood pressure at home. So all of these are things that can be shared and replicated. So we encourage folks who are interested in engaging in adopting this practice in this project at their site to look through these resources and let us know in the future if you have any questions or need support. So I think now we're going to go into a little bit more about the data that we tracked throughout this project. Oh, I have one more slide, sorry. We do also have available a sustainability change package. So once sites have engaged in implementing the clinical change package and achieve the results that they're seeking, this is a resource that can be useful in sustaining the gains achieved at a practice level. So this supports some of the best practices and policy changes that should be put in place at the site level to support long-term success and address those institutional policy needs. These are complementary, but not necessarily repetitive of what's in the original change package. So we encourage folks to check out both of those resources if you're considering using one or the other. Okay, now I will turn it over to Evelyn to talk about some of the data available.
Thank you, Ali. Next slide, please. So on this slide, we're looking at the percent of adult patients with the hypertension diagnosis. This shows that the rate has been pretty stable over time. We see a very slight increase from start to the end. So our center line starts at 32.3%, and at the end, we are at 33.2%. We see 3 shifts in this measure. The first measure is a shift. Is a shift up at around January of 2022, and then we see a shift down at around May of 2022, and then we see another shift up at around September 2022. Next slide, please. Here we look at the percent of patients with diagnosed hypertension in control. For this measure, we see an uptick right around March 2020 to May 2020 in the baseline period. And then after the baseline, we see 3 shifts as well. The first shift is a shift up at around September of 2021. And then we see another shift up around February of 2022. And then a shift down at around October of 2022. So overall, we see a very slight increase in this measure as well, starting at 74.7% to 76.2%. Next slide, please. Here we have the percent of patients with diagnosed hypertension in control, stratified by race and ethnicity. The blue line depicts the non-Hispanic white, and then that's the light blue, and then the dark blue is non-Hispanic blacks. Here we see that over time, the rate of hypertension control is higher for non-Hispanic whites compared to non-Hispanic blacks. And overall, we see 1 shift in this measure and around the baseline period. Next slide, please. Here we look at hypertension control in Black patients broken down by sites. And we compare our implementation median to a baseline median. So there's 11 sites overall. From the bottom to the top is site A to site L. And we can see that 9 out of the 11 sites show an improvement in hypertension control. For the baseline median is depicted by the dark color here, dark brown color, and then the median for the implementation is depicted by the red color. And then you can see that for most of our sites, the rate during the baseline median is much shorter than for the implementation period, which is showing that overall there's an improvement by site. Next slide, please. Here we assess whether we close the gaps in hypertension control, and we compare the disparity of hypertension control for non-Hispanic whites versus non-Hispanic blacks, comparing our baseline to our implementation period. And this is also broken down by sites. So we show site A from the bottom to the top, site A through site L. Again, here as well, we show that 9 out of 11 sites have the gaps closed. We show that the baseline disparity is depicted by the gray color, And then the implementation is depicted by the red color. And you can see that we have a longer column for the baseline compared to the implementation. So over the project period, the gaps are closed because we have a shorter rate comparing our implementation disparity to our baseline disparity. And that is all I have for data. I would pass it back to Wendy.
Thank you so much, Evelyn. We appreciate the update on our data. I wanted to check in and see if anyone has any questions. Feel free to put them in the chat box. Otherwise, you can always feel free to reach out to myself, and I will have my email address coming up momentarily. Also, the website for our ACE project is listed on this slide as well. I will follow up with an email probably within the next day, definitely by the end of the week, with these materials as well as the link to our website that does contain both of the change packages. So we would, as a team, we would like to thank you very much for joining us today. And we hope that you were able to walk away with some interesting information that you can apply to your practice. Thank you so much for joining. Have a great day.